Hello, everyone, and welcome to the Medical Toxicology podcast series for Ukraine. Today, we are going to talk about bomb-related injuries. My name is Ziad Kazi. I'm a professor of emergency medicine and medical toxicology at Emory University. I've been teaching about explosion and blast injuries since 2006, and wanted to share with you today some of the important points of caring for bombing victims. This is a podcast series that's brought to you by 4 nonprofit organizations: GRM, IDMC, MINATOX, and ACMT. I'm going to try to keep this brief, but high yield for you. And hopefully at the end of this podcast, you'll be able to list the 4 types of blast injuries and discuss important emergency department assessment and management steps. I always think about 3 elements when I assess a patient after a bombing. These elements are the agent, host, environment. First, I try to think about what I know about the chemical explosive that was used, its size and its identity. Is this a high order explosive or a low order explosive? We'll talk about that in more details shortly. I also would like to know if the explosive was adulterated with other type of solid materials like nails or ball bearings. Of course, occasionally you will see additional chemicals or radioactive materials added to the device, even sometimes biological toxins or microorganisms or biological organisms. It's important to think about the host or the patient or the victim here as well. Specific characteristics, age, gender, access to care. Are these civilians or are these members of the military that potentially have Kevlar helmets and body armors? Of course, the older you get or the younger you are, the potentially more severe injuries and outcome you have. And don't forget about access to care. The location of the nearest paramedic or nearest hospital are also important. Finally, think about the environment where the explosion occurred. If this is a bombing that is in an open space, you have more likelihood of getting injuries far away from the actual device, because the fragments can travel a long distance without being stopped by a wall, and they can injure people at a long distance. I remember this happened, for example, to my dad in 1982 when he was injured in a random bombing in Beirut. And he was far away from the device or the bomb that fell on our building, and yet he had 2 fragments injure his foot and his head. It's also important to remember that when you have on the other hand, an explosion that happens inside of a enclosed space like a building, then in that case, you have less of this large perimeter of injuries potentially, because the fragment can stop at the walls. On the other hand, in an enclosed space, if you have a high order explosive and you have a primary blast wave that is released from the explosive, it tends to be amplified inside this enclosed space, and that can lead to potentially more severe and more commonly seen primary blast injuries. This is not the case in an open space, where the primary blast wave of this high order explosive will dissipate in the environment, leading to less primary blast injuries. So again, I just want to illustrate this concept of high versus low order explosives. Remember, the chemical is going to be releasing energy in the form of pressure wave and heat. And if it's a high order explosive, the pressure wave is going to be traveling at a supersonic speed, and that will lead to specific primary blast injuries that we'll list shortly. The example of high order explosives are what you see usually with the military grade devices like C4, of course, ammonium nitrate, dynamite, and TNT. Contrast that with low order explosives that do not have this supersonic primary blast wave. They do have a blast wave, but it's not supersonic, and therefore do not necessarily cause these primary blast wave injuries. These chemicals like gasoline or gunpowder will explode or deflagrate at a subsonic speed and will cause, again, the other types of blast injuries, the secondary, tertiary, and quaternary blast injuries. However, the high order explosives are going to cause, in addition to these 3 types of blast injuries, the primary blast injuries. So that's always important to remember. Now, when we will talk about the injuries from these blast incidents, we will go ahead and list them into 4 categories that I will give you more details on. But it all happens because of the release of this energy from the chemical and heat when it explodes. This video from Beirut shows a victim of the bombing of the ammonium nitrate explosion at the port. And you can kind of see the four different types of blast injuries in the video. You can imagine an invisible primary blast wave going through her body, affecting her eardrum and her lungs. You can then see the secondary blast injuries from the fragments that are flying towards her. You can also see the tertiary blast injuries as she collides with the rail. And of course, you can see the smoke that she potentially inhales. That's an example of a quaternary blast injury. Now let's go ahead and talk about the individual blast injuries. The first one I'm going to talk about is the primary blast injuries, the most common of which is tympanic membrane rupture, which can often be bilateral. And again, it's from that primary blast wave going through the eardrums and rupturing them. People can present with hearing loss, ringing in their ears or tinnitus. They can even be having vertigo or dizziness and vomiting. Typically, these injuries require supportive care. The tympanic membrane heals with time. You could potentially decide to use some antibiotic ear suspensions, but again, they'll heal on their own. Avoid having water enter these injured tympanic membranes. And typically the outcome is good. Some people may have some more significant hearing loss. It can be permanent. Again, it depends on the severity of the injury. A follow-up eventually with an ear and nose and throat specialist is a good idea. The second most common type of primary blast injury is blast lung. Now, this is interesting because it's difficult to differentiate a true blast lung from a blast wave going through the pulmonary tissue and causing this inflammation from the typical chest wall trauma that you can see with these type of traumatic mechanisms, rib fractures, pulmonary contusions. The strict definition of a blast lung is when you have no external thoracic trauma, but you have this inflammatory process from the primary blast wave going through the pulmonary tissue and showing up with this butterfly bilateral symmetric. Now, whether these injuries are survivable or not can be a controversial topic. There are reports of these in victims that have survived, particularly when the explosion occurred in an enclosed setting where this primary blast wave is amplified because of the enclosed nature of the environment. In an open environment, to get the primary blast lung injury, you probably were too close to the device and probably have died from other traumatic injuries. The other type of primary blast injuries, the third most common one, is the visceral injury, which is basically injury to the colon or small intestine with perforations and hemorrhages. Now, it could be early on, you can see it immediately, but it can also be delayed and due to more of an arterial vascular compromise to the intestinal tract. So in examining the abdomen, initially looking for tenderness or peritonitis, also looking for this in people that present in a delayed fashion, remembering that if they were involved in a blast injury scenario, that they could have this delayed visceral injury. Again, here you have to manage these and assess these depending what you have as far as resources. Your eardrum can be assessed with a direct exam. The lung can be assessed with a chest X-ray. The good news is that people that have a blast lung will be symptomatic early on, and there's no risk for delayed onset pulmonary injuries from these blast lung mechanisms. Typically, it is recommended that within 4 hours, if you don't have any symptoms like cough or chest pain, and of course, if you have it on top of that, in addition, chest X-ray that's negative, then you are less concerned about having a primary blast lung injury. If you do have a primary blast lung injury, then of course admission is warranted, and you manage this as the pulmonary contusion. Thinking about the globe of the eye is also important. That's another organ that can be damaged with the primary blast wave and rupture. So looking at the size of the pupil, the shape of the pupil, the intraocular pressures, the visual acuity, all of these are hints whether the globe is intact or ruptured. And if it is ruptured, of course, you have to consult an ophthalmologist and cover the globe, protected from leakage of the fluid that's inside the globe. Primary blast injuries also include head injuries, whether it's intracranial hemorrhage, contusion. All of this should be assessed, of course, with CT scan imaging of the head. In terms of secondary blast injuries, these are now due to the actual fragments that can penetrate the body of the victim. Now, this is here primarily a traumatic management, trauma management from penetrating mechanisms. Finding these fragments can be difficult because they can be in a number of them and they can be in different places, and you may be limited on your diagnostic capabilities. Many times you may tell the patient to come back for follow-up, especially if these are minor fragments that are in the skin or in the head, in the scalp, in the hair. They may be difficult to find and remove. Of course, they increase the risk of infection, and you may need to think about antibiotic for these patients. Now, if you do have diagnostic resources, the CT scan or even plain films can help you find some of these radio-opaque fragments. But again, on physical exam, they may be difficult to discern initially, as you see here from the hole in the chest and the nail in the lung, or here from the nail in the brain that actually entered the brain through the mouth in the specific case. And remember also, lastly, that these secondary blast injuries can occur at a long distance, especially in an open space. And of course, when I'm talking about the management and assessment here, I'm keeping in mind that you may or may not have the specific diagnostic resource that is needed in these scenarios. Sometimes if you don't have the imaging available, you have to rely on a clinical assessment and reassessment. With these penetrating injuries from fragments, a lot of mortality can happen from exsanguinating, life-threatening bleeding. So applying a tourniquet can be life-saving. We are going to have a specific vodcast on that coming out soon. But tourniquets and direct pressure are essential for these life-threatening bleeding situations. Use of additional hemostatic agents can be done. It's outside the scope of this specific basic podcast. We will prepare something specific on that at a later time. If you are going to add to the tourniquet 2 other life-saving interventions, I think airway is definitely high up there in the high-value procedures that you can do, as well as a chest tube or needle thoracostomy to relieve attention pneumothorax. So if you have these 3 life-saving interventions in mind, stopping the bleeding with a tourniquet or direct pressure, securing the airway by intubation or some sort of temporizing airway measure, and relieving of attention pneumothorax, these are the 3 proven ways to save someone's life after a blast injury. Because otherwise, people typically survive if they don't have a pneumothorax or they don't have an airway compromise or a life-threatening bleeding, whether you do all the procedures in the world or not. So these 3 life-saving interventions are definitely your highest yield for your victims. In the emergency department, we often use a bedside ultrasound to look for lung sliding and try to detect pneumothoraces. We also use them to look for intraperitoneal blood. That's easy procedure to be done if you have the ultrasound machine, and will save you the need to get CT imaging, especially when you're in a mass casualty incident. The other types of blast injuries I want to talk about are tertiary blast injuries. Those are, again, traumatic injuries to the skeletal muscle, the head injuries, and you can have bony fractures, pelvic fractures, spine fractures, and the management here is really based on your typical trauma management. One particular syndrome that you may see is crush syndrome. Victims that are entrapped under the rubble can develop this illness, which can lead to acute renal failure, metabolic acidosis, and hyperkalemia, and cardiac arrest. And the management here is definitely with IV fluids to keep the myoglobin excretion to the urine. Dialysis may be needed for some of these victims that develop renal failure. Some people select to do bicarbonate intravascularly to alkalinize the urine, as well as IV mannitol, but that really is controversial. Some people would prefer to manage this only with IV fluids, supportive care, and dialysis as needed. Last but not least, your 4th type of blast injuries are your quaternary blast injuries, and that's everything else. This is your smoke inhalation, this is your mental stress, mental health effects, this is your contamination with chemicals or radioactive materials or biological toxins. This is even exacerbation of other illnesses like your asthma, your lung disease, or your heart disease. So this is really everything else that is not classified as primary, secondary, or tertiary blast injuries. And the management of these specific injuries depend on the specific mechanism that you are dealing with. Last but not least, remember that if you have an ability to send victims that have minor injuries to hospitals that are further away, it's better than sending them to the higher level acuity hospitals that are nearby. Keep your trauma centers and higher acuity hospitals for your critical patients, and try to properly triage patients with minor injuries to hospitals that are further away or even to alternative care site to keep your precious trauma centers with capacity to take care of the more severe injuries. Again, I hope this was useful to you. I want to summarize what we learned. We learned the 4 types of blast injuries. We talked about the high versus low order explosives. We also talked about the agent host environment assessment. And then I actually went through each one of these injuries. We talked a little bit about their management. And remember, the 3 life-saving interventions are airway, relieving a tension pneumothorax, and stopping a life-threatening bleeding with a tourniquet or direct pressure. And thank you for listening. Follow me or email me using the following information, and see you soon.